So you might just want to contemplate how you're going to put this information down, okay? How it makes sense to you. But one of the things that PTA students, graduates, tend to struggle with on the boards and in the clinic is data collection. They don't realize that half their job is collecting data. Only half your job is intervention. The other half is collecting data about your intervention, documenting it so you can appropriately bill for it and show progress and all that. So when you're talking about data collection, you're talking about a whole lot more than what you might realize. It's not about patient ambulated 100 feet with a standard walker, min assist times 1. Like, that's not data collection. One of the handouts, Denise, did you give them the critical work activities? That critical work activity sheet has every system listed, and then in parentheses, it has all of the data, all of the indicators and markers that you're supposed to be writing down about stuff. So when they talk about heart rate, they're talking about, is it regular? Is it bounding? Is it thready? Is it is there respirations labored? Are they, what's their breathing like? How do you describe a wound? All kinds of data. Yep. And that one's the non-critical. It looks like this, but there's a bigger one. This is the stuff not to study because it's deemed that this is nice to know as a PTA, but it's not on your test because it might be post-entry level. The not critical is just as important to look at, but don't study that stuff. Just know that, hey, I don't have to study cupping. It's not on the test, okay? No. Ionto, I believe, has been removed.
So she said that there was a question about it.
That's interesting.
That's what I thought too. That's what I okay.
Yeah, okay. Well, it's good to know then.
So I thought
this is the content outline, but there's one more.
They have those.
That's the not critical one.
Yeah, we need the critical one. There's 2. And I'll show you. So maybe you guys still need that. Okay, yep.
No, you didn't get it.
So I'll get you that, and I'll explain how that is a great study guide.
It looks just like this, but
It's thicker. Okay. All right. So when you guys did your last score builders, I printed out what you provided as far as your answers and your analysis, and we'll give those back so you have a printed one. And the goal was to see where was the trends. You don't have it? I'll have to email it. I'll pull it up. Well, you know what? Let me pull it up and I'll put it on the screen. All right, let me find it. Let's make sure I have the one from this year because they just updated. And we'll get this emailed to you. So every 10 years, all licensed PTs and PTAs are surveyed. It's a huge study. Every 10 years, you'll get one in a few years. And they will ask you a million questions about what you do on your job. Like, do you do wound care? Do you do whirlpools? Do you do this? Do you do that? And from that, they will put together a list of what is the current contemporary practice of PTA. If they find out that, you know what, almost nobody's doing wound care anymore, the nurses have taken that over, then there's going to be fewer questions on the test about wound care. And then they find out what they're doing a lot more with the cardiac patients. So they're going to increase the questions in cardiac. So what they produce, the product that they produce is this document called Critical Work Activities. And they determine with a very statistical study what are the critical work activities for a PTA? Okay, great. I'm going to pull this back up and see if it reads. Oh, I think I just have to, there we go. I'll do it this way. It's right there. Oh, it's up there somewhere?
It's treating like a second desktop. If you just drag that whole window to your right, it'll put it up there. From the
Computer.
Sorry.
Sorry.
Gotcha. There we go.
Double click the middle bar.
There we go. Oops, wrong way. Okay, here we go. Critical work activities. Now, the first section is called data collection, but look at just some of the things on here. Administer standardized questionnaires, pain inventory, fall risk assessment, identify signs and symptoms of change in patient client's health status. Identify signs and symptoms of change in patient client's health status that require intervention by interprofessional, interdisciplinary team members. So, let me go to a system. Let's look at your general, okay, therapeutic exercise. So, it's not about sets and reps, is it? It's not. It's about movement patterns, neuromuscular re-ed, relaxation techniques, pelvic floor exercises, bladder strategies, airway clearance. This document itself gives you a lot of things to look at to go, do I know what that is? Would I be able to write on that? Let me go to the musculoskeletal. Oh, cardiopulmonary, right here. Okay, here's where we're at. So when you're looking at the cardiopulmonary system, yes, you have blood pressure, heart rate, heart sounds, but you also have respiratory rate, breathing patterns, breath sounds, chest excursion. Do you know how to measure chest excursion? If you're like, I've never heard of that, that's something to look up. Everything in the parentheses, you want to look it up. We know about O2 saturation, right? Pulse ox. Capillary refill. Can you do the special test from Big Red? You know, at the end of those chapters, they have all those vascular tests. Blood pressure, upper versus lower, the ABI index. Do you remember what that is? Have you heard of that before? Yeah, like it's supposed to be like 1, right? So what if it's 1.2 versus 0.7? Yeah, which one? Okay. Pulses, all the places for pulses. So this document really helps to kind of guide your studying. You're like, okay, I should be able to kind of run through all of these. This is stuff you're supposed to be including in your documentation, okay? Not just the intervention. To report your patient's status. So this can be a little overwhelming as a list, but it's a really nice list because this is created by the same people that wrote the test. So I'm hoping the two are connected, right? Test questions and what they think is critical for you to know. So this document will be helpful for you, okay? So that's one little bit of information. But so what I want to talk about is connecting all of your data collection and your treatments.
Yeah.
All right, so here we go. This should be pretty easy. This I think you're going to be able to roll with. Okay. When you're talking about heart rate, what are we measuring? Beats per minute. Okay. We know that. What is normal? And we'll start with the adult, and we'll talk about kids later. But for the average adult, normal heart rate, bro? 60 to 100. What is low? Bradycardia, right? Less than 60 is Brady. And what do we call greater than 100? Okay. Now, where do you measure pulse?
Yeah, there you go.
Where do you measure pulse? Yep. What is that structure that you're pushing on? What is the structure you're pushing on to take a pulse? It's an artery. Just know that it has to be an artery, not a vein. It's an artery. What are all the pulse points in the body? No, jugular is a vein. What's the artery version? Carotid. So you got carotid. You've got what else? Brachial. Radial, which is the one we mostly use. Let's work our way down. Is that it on the upper? Okay, then your basics, you're going to have femoral, popliteal, and then dorsal pedal, right? So that's
This is all in the same box?
this is going to be in that column, yeah. Down heart rate, yeah. Those are all the places you can take pulse. How do you document the strength of the pulse? Did you use the 0 plus, 1 plus, 2 plus, 3 plus? What the what? We want to know what those are. So 2, is it a 2 or 2 plus?
I don't remember this at all.
Okay, so look in your score builders on, just look up pulse, and it'll show you how to classify those. You might want to mark that with a sticky. Yep, bounding, threading. So this would be a good, because this is data that you really should study, because they're going to hit you on this stuff.
Yeah, that's that pulse oximeter.
2 plus is normal. So always start with the normal and go up and down.
3 plus is large or bounding. Yeah, it's 387. And then 1 plus is small or reduced.
Okay, so 1 plus, and then
3 is bounding and 0 is nothing.
What does it mean, large or small? Like a large, like thump, you're like the feeling, or?
and comparatively speaking, you have to have felt a lot of pulses to know, right?
Yeah.
Yeah.
I'm like, I won't.
1, 2, 3, 4.
Yeah.
Okay.
If you have to push hard, and if you need the room quiet to feel it, it's probably like, how many of you need it quiet to feel a pulse? I do.
And do you just mark that down for like the next person coming in to know how to do it? Pretty much?
This is all part of data collection for heart rate. Everything having to do with heart rate. So what I'm doing is I'm taking a really deep dive into heart rate. Then we're going to talk about what affects heart rate and why you would then need to collect data on a patient during a treatment based on all the factors that could be contributing. So I'm hoping to pull the classes together. Yeah.
So I know a lot of times we take heart rate with the pulse ox.
Mm-hmm.
Is there a way to tell the grade on there, or you take
Nope.
it manually and add that in?
Yeah. So if you really want to give this data, you would have to do it manually.
Okay, because I was going to say most of the time we don't do that
Right.
as much anymore.
Why would you want to do it manually? Who would you want to do that for? Maybe the cardiac patient. Maybe you don't want to just, maybe a quick pulse ox for your low risk person. But if you really need to know, you would want to do it manually. So let's talk about that. How many seconds do you count for? What is acceptable practice? How many seconds do you count for and multiply by what? It's per minute, but you can reduce it to 15 seconds. That's the correct. Not 10 seconds by 6. That's not standard. It's 15 seconds by 4. So it should be an even number. There will never be an odd number on a pulse. Don't look like you don't know what you're doing. Don't give 57 as a pulse. That's liar, liar, pants on fire. That you didn't count it then. If you multiply by 4, it's going to be an even number, okay? All right. All right. So if it's absent, obviously it's 0. What would 0 indicate? What is the danger of a 0 pulse anywhere in the body? There's no blood flow in the arteries. What would cause that? Blockage. What would cause that? Where's the DVT? Well, depends on if the DVT breaks loose, because that's in a vein. That's what the V is for. Okay, but it could break loose and land in an artery, and that's what you call a stroke or a heart attack. So yes, it could be a clot that landed there. Denise, do you have another vital sign chart? Awesome. All right. Well, hello, welcome. Okay, so we're talking heart rate here. So what would be the danger? Would this be an emergency situation? You're doing therapy, you go to take a pulse, and there's no pulse. Well, we're not talking about radial pulse here because that would be dangerous. What about dorsal pedal? What would you see in their feet if there's no pulse on that side? Oh, wait a minute. Yeah, there's no pulse, so there's no blood flow. White, cold. There could be inflammation from chronic vascular problems, but basically, if we're going to oversimplify, it's the cold white leg. If it's venous problem, venous insufficiency, it's going to be thick, warm, purple, ugly, nasty, soppy veins. Now, which one of those two would cause amputation? Arterial occlusion or venous occlusion? Arterial, because there's no oxygen coming. Okay, arterial is like your yard during a drought. The grass is dead. There's been no water. Dead. Venous insufficiency is the Everglades swamp. Too much water, mucky muck muck, nasty, stinky. Neither one do you want, but yeah.
Does the arterial, you'll get the ulcer on the outside of your,
So now we're jumping to ulcers off of heart rate. You see how that works? All right. So let's look at, we're jumping to the ulcer types based on the rest vascular. If you have an arterial ulcer that could lead to amputation, it's going to be the lateral, yes. You're talking about outside. Will the wound be dry or moist if it's an arterial ulcer? Dry. It could even be neuropathic. It could be a diabetic ulcer. Like the priest who went golfing in his shoes with the keys in there and didn't even know. So the arterial ulcer is going to be maybe eschar, maybe black, dry, dead, gangrene. Cut the toe off. Maybe the toe's floating in the water after the whirlpool. I don't know. If it's venous and it's venous insufficiency from the saphenous vein, from the valves not working, the calf pump not returning blood flow, that's a flooded basement. The sump pump stopped working. That's nasty, but all you have to do is get the water out. You know how we do that? We elevate, we wrap, we compress. We can get the basement cleared out. But if there's no pulse, that's a medical emergency. If there was a pulse yesterday and there's no pulse today, you have to tell somebody. Something's occluded, and it could be a tumor. It could be some kind of growth, especially if it's rapid. Okay? So that was a nice jump from the heart rate conversation. Okay, let's keep going with the vitals here. That was good. Okay, so what are some things? First of all, what in the heart regulates heart rate? What structure regulates your heart rate? Okay, in the structures now. Come on. Yep. The which one? Not the aorta. Not heart rate. It's electrical. It's a pacer. What's your pacer? The node. Which one? Where's your pacemaker? What's the first main one? You got two. Sinoatrial node? SA node?
And AV.
And then AV. Which one is the main one that's going to keep you at 60, 70? So we've got the SA node. And if that fails, you have a backup, but it's not something you're going to want to live on by itself. The AV node, and what's the heart rate of the AV node as a backup? When the backup generator goes on, you don't get full function. That's going to be 40 to 60. It's going to be low, but it'll keep you alive until someone picks up, hey, you're not pumping well. So the AV node, it's a lower rate, but it'll keep you alive. Okay?
What did you say was for the SA?
That's going to keep you at a nice normal 70, whatever. Yeah. Okay.
That's your normal rhythm.
Yep, normal rhythm, and AV is your generator backup. You won't have energy to do anything, but you will still be alive. Okay? Now, heart rate fluctuates based on the demand placed on it, right? So what is the target heart rate for exercise? Let's talk about that. You said earlier it was 220 minus your age, and then what? How do you, I'm 57 and I'm going to get into aerobic exercise program. How do you determine what my heart rate should be?
You got a multiplier, don't you?
Yep, you have a multiplier. Nope, now you're talking oxygen. We can't measure that with my heart rate, but is it just 220 minus my age?
No,
Am I supposed to have 163 beats per minute? You're going to kill me. I am very out of shape. At what intensity do I want to exercise? 100%? This, okay, so what is 220 minus your age? That's your max heart rate. That's what that's called. If I'm running away from an ex-murderer, I'm going to be pumping at that. Okay, which declines with age. My ability to get my heart going declines with age. This is a very rough estimate, by the way. But I don't want to exercise at that. I don't want to exercise at 163. What do I want to exercise? What intensity of max? 70%? Sounds like a good number. 60 to 80. 70%. How do you get that out of this? You times it by 0.7.
Did we just throw 70 out, or is that like a thing to memorize?
No, it's in there.
80%.
Yeah, 70 is a good start.
Okay.
Yeah. Sitting still, I'm probably at 50% my max heart rate. If you're a smoker, you're sitting at 50, 60% of your max heart rate because you already got, flutter heart there. Okay, so this, I just made that up. So I got 163 times 0.7. So is that 141? So what is 141? That's your exercise heart rate. I'm going to call it EHR. Don't get it confused with electronic health records. My exercise, let's do target heart rate, THR. Not to be confused with total hip replacement. My target heart rate is that. Now, what if my resting heart rate is atypical because I'm on a beta blocker for my CHF? Thank God I don't have that, okay? I'm on a beta blocker to slow my heart rate. And so I could be running uphill from an axe murder and I'm never going to hit 141. Like my heart rate is stuck low. So what's the other method of calculating it where an atypical resting heart rate can be figured into this so that it's appropriate for me? You know that one? Nope.
No, I thought you just minus it by 20.
Nope. Have you heard of Carbonin's method? Have you ever heard of Carbonin's method? To take out the resting heart rate and add it back in? It might be too much to okay. Okay, Carbonin's method, just so you know this academically then, maybe it's going to be enough for your question, okay? Carbonin's takes into account a person's atypical resting heart rate, be it high or low. Let's say at rest I'm 99 beats per minute. 98, it shouldn't be odd. 98 beats per minute for whatever reason. And I'm 70 years old. 220 minus my age, that's 150. And I want to exercise at like 70%. What's that? 95 beats a minute? 105? 7 times 0 is 0, sometimes 5 times 3. 105. So if my target heart rate's 105 and at rest I'm at 98, I could start going, I could get there. So obviously my target heart rate needs to be a little higher than the average 70-year-old that's how old I was and that's what I had, okay? So Carbonin's, I'm going to spell it for you so you can just at least have it in your head. It takes, you still do max heart rate, which is what? 220 minus your age. That's max. Times your intended intensity for 70%. That's this, but then you minus your resting heart rate out of that. Okay?
That, and we also do
Like,
RPE.
yeah. But then you add the resting heart rate back in. Okay? So that it's at the end. So I have to make sure that I do this right for you. And if not, I'm gonna pause and not give you the wrong way. Check 390 in your score builders. 220 minus your age, minus resting, times your intensity, and then add the resting heart rate back in. Okay, so mark that with your sticky. We don't want to burn all our afternoon doing that. Okay, so that's for someone with an atypical resting heart rate that really should either be higher or lower than the average target 220. All right, so we can jump on. All right, so you got the SA nodes, AB nodes. All right, now let's talk about what would make somebody bradycardic, besides the fact that maybe their SA node went to pot, you're living off of this, doctor's going to put in a pacemaker. Okay, that's one easy fix. All of a sudden it's like, wow, I have energy again. Grandma feels a lot better now that she's pumping at 72 beats a minute. What would cause tachycardia? In order to have this conversation, let's remind ourselves, what is cardiac output? Heart rate times stroke volume. Okay, have you seen that before? Okay, so cardiac output has to remain stable or you die. The equal sign is life and death. Cardiac output has to equal heart rate times stroke volume. So if my heart rate is up, what went down? If this stays equal, stroke volume went down. So I guess my question is, if you have a heart rate of 100, what caused stroke volume to go down? That means I'm pumping a lot more because I have just a little bit pumping versus, okay, I'm just spitting blood out of my heart. So it has to do it a lot more in a minute. Okay, so let's look at congestive heart failure. In congestive heart failure, the left ventricle is not pumping very well, right? And so the blood is backing up into the lungs. It's waiting at the front door. It's not pumping. So if you have a high heart rate and low stroke volume, that could be a cause. So what do they treat that with? How do they manipulate this? They lower the heart rate. How? Beta blockers to medically force the ventricle more time for preload. If you have a stroke volume that becomes very small and you aren't stretching the heart muscle to contract, what do we know about the stretch on a muscle to contractility? Does the stretch impact the strength of contraction? Yes. When you're dealing with cardiac muscle, what do you call the law or the principle that says the more you stretch a heart muscle, the more it loves and the more it's going to be able to contract? It needs stretch. It needs filled up in order to contract. Otherwise, it's just kind of nothing. Ever hear of it? Say it again. S. Starts with an S. Say it. Anybody? Starling's. Starling's principle. You know how in a skeletal muscle, if a muscle is weak, what do? You put it on a stretch so it has more potential to contract. Like that stretch strain curve. For a cardiac muscle, its version of that is called Starling's. So you have to give it more fill or it won't pump. If somebody is in cardiogenic shock, right? You go to a scene of an accident and they're like, oh my God, they're going into shock. Shock doesn't mean, oh my God, I'm in an accident. Shock means your blood is running out of your body. And so your stroke volume is so little that this now is like at 250 beats per minute and it's not sustainable. That's what cardiogenic shock is. So they need to pump them full of like water or something so that we have some kind of stroke volume so the heart rate is sustainable. Does that make sense? So tachycardia could be caused from low stroke volume. So it could be because the heart itself is sick and isn't able to pump more, But let's think of a less chronic reason. You would be in an episode of tachycardia. What's a more common one that a healthy individual could actually experience and go, why is my heart rate so high? It could be that. Dehydration. Does that make sense? If the patient is dehydrated, are they not going to have tachycardia? Medications. So if the patient is dehydrated, what do they need? They need water. So it would be a sign of dehydration. So that could be in the question. The patient is demonstrating a high heart rate and this or that, and then they're going to give you clues like they're dehydrated. Okay, so you see that? So be able to make that connection. Okay? All right. Let's look at how this relates to blood pressure. All these ways and reasons why you'd be collecting data. Okay, what is blood pressure actually measuring when we do it? What does it measure? We're not measuring the pressure in the heart. You've got a systolic and a diastolic. Which one's on top? And diastolic. And what's normal? And what are we actually measuring? What's that one, and what units is that measured in? What kind of mercury? Millimeters, right? mmHgs? Okay. What is 120 millimeters of mercury measuring? Like, what's happening during the moment that you say it's 120? Like, what's 120 millimeters mercury? Pressure where? In the artery. And which one do we typically measure? Yeah. Yeah, the 120 is the systolic. It's the pressure in the brachial artery, right? What's happening in the heart when that is exerting 120 millimeters of pressure? What part of the cycle of the heart are we in? It's contracting, right? And then what's the diastolic a measurement of? The relaxation, okay? This difference is ejection fraction. Okay, so this is the difference. We don't want to pump our ventricle empty, do we? We don't want this to say 30. Like, it needs to keep some. You know why it needs to keep some? Because it likes to be stretched to contract, and you don't have enough time in 1 second to fill it all the way back up. So you leave it half full. Okay? Our normal ejection fraction is 50-60% based on this. So if someone has a 20% ejection fraction, it's either staying pretty full or it's always half empty, and we're not, okay? So we want to see this difference here. Okay, you could measure blood pressure at other arteries, couldn't you? If there was a problem. Reasons we couldn't take a blood pressure, we said today, was a fistula from dialysis. What other reasons would you not take a blood pressure in an arm? If there was lymph nodes removed after a mastectomy or other reason, right? So you'd want to go on the other side. What else? A port, IVs, wounds, burns. What's that? For whatever reason, all right. So let's say you have to go to some other area. What would be the next best place to do a blood pressure? You can't use the carotid. Besides the other arm, you could go to the leg, right? And so if you're going to basically put the cuff to stop the blood flow, you're going to be listening to the artery with your stethoscope distal, and when that pressure of the cuff matches the pressure in the artery, that's when you hear breakthrough flow. That's what you're hearing, okay? All right, so this is the contraction, which they call systole, and then this is the relaxation. All right. What would cause blood pressure to go up? It does go up during exercise. Stress. Diet. Everything good for you, right? I mean, fun. I mean, right? What would cause it to drop? Dehydration. Blood loss, low blood volume. At what point is it hypertension And this is a moving number all the time. The cardiology. So, but at what point do we name it hypertension? What is the current? Used to be 160. Now it's 139, right?
Yes, stage 1 is 130 over 139. Pre is 130 over 80 to 89. 130 to 139 over 80 to 89.
Aye, aye, aye.
That's
What?
stage 1.
Stage 1?
It's on page 380.
Okay, so page 380, you want to know your guide to that. Okay? Again, know your basic numbers.
Right.
Another cause of high blood pressure is increased arterial resistance, right? Atherosclerosis. Okay, let me throw a term in here. What are the modifiable versus the non-modifiable risk factors for hypertension or cardiac disease? Because that could throw you. What's a modifiable risk factor mean? You can change it, yeah. And non-modifiable, yeah. So if being female is a risk factor for adhesive capsulitis, that's a non-modifiable risk factor that I have. Contrary to some belief, I can't change my gender, okay? I'm a woman. But I can't change my age, but I can change whether I smoke, exercise, eat a low-fat diet. So make sure you understand the difference between modifiable and non-modifiable, okay? All right, so blood pressure there. Let's look at the vital sign of respiration. In what unit do we measure respiration? Breaths per minute, not to be confused with beats per minute, right? So you could, you know what? How do you guys document, how are your clinics here documenting respiration rate? RR? Because they're not going to do BPM. Okay. So let's do RR. And what is normal respiration for an adult? 12 to 20. All right, so let's pause there and let's go back. How does a child's heart rate compare to an adult? It's higher. Why do you suppose it's higher? Because they're littler. And in order to get enough, their stroke volume's itty bitty. They need a higher rate to, okay? How does blood pressure compare in a child? Lower. How does respiration rate compare in a child? What do you think? Do kids breathe faster or slower than adults?
Faster.
They do. Okay? So in utero, when you're doing the ultrasounds and everything at the doctors and they're telling you your baby's heartbeat, what is that range for a neonate? For a girl, yep, up to 150 for a boy or higher. Then you're born and you're like around 100, 120, like newborn infant, right? Blood pressure could be for a child, it could be like 90 over 50, okay? And then respirations is, we said it was higher, okay? So it could be like, 18 to 24, okay? While we're on respiration, do you know what the irregular breathing patterns are for a newborn? It's normal, but it can be very scary because sometimes they stop breathing. It's like, if you ever watch a newborn breathe, I could do that for hours. They're learning how their lungs are fitting in their chest cavity. So it's really bizarre, and their nervous system is developing at a rapid pace, and they're trying to get those signals, as you mentioned, the brainstem. So do you know what that kind of normal, abnormal, neonatal breathing pattern is? Not to freak out about, but if it happens in an adult, there's probably head injury involved. It's called Cheyenne-Stokes. Have you ever heard of that? Okay, so in a newborn, it's actually normal to have those pauses and those increases, and they're all over the place. Ooh, that's high. 33, 45 for newborn, and then for a child. And then for a child, it settles to what? Do you have like a 8-year-old?
1 year's 25 to 35, 10's 15 to 20.
Okay, so by the time you're 10, you're already almost at an adult breathing level. Yeah.
Is the Cheyenne-Stokes, is it also called the death rattle? And you can have it as a baby, or?
I've not heard death rattle for babies, only for dying people.
But it's the same thing
yeah,
that's happening in the respiratory.
Could be. Yeah, I hadn't heard it like that.
I'm pretty
Okay. Yeah. All right. So for respiration, what is the normal oxygen saturation? Pressure is what?
Greater than 92.
So we want it to be like up to 100, but most pulse oxes won't read 100, but it will read a 99. But we want it to be all oxygen, right? What is the normal pressure of CO2? This is what you were asking a little bit about blood gases and things. What's the normal oxygen level or CO2? You won't measure this, but the respiratory therapist will when they draw blood gases. Anybody know? Does it have it in the same chart there with your PO2s? Around 40 to 60. You want this to be less, like low. Now, again, you're not measuring this, but just if someone has a PCO2 of like 80, they're like in carbon dioxide poisoning, okay? All right. So PCO2 is going to be a lot lower. Then, of course, you've got your oxygenated versus your unoxygenated blood. So obviously your red blood, oxygenated, is up to here. When it's exchanging it and you're exhaling the carbon dioxide, your veins will have a higher amount of carbon dioxide, and that's normal, okay? I think it goes from 40 to 60, okay? All right, respiration rates. What are breath sounds? What are normal breath sounds supposed to be?
Clear.
Clear, right? And then all the lobes. Do you know how many lung lobes you have? Where's your heart? So they say 2 over here, 3 over here, right? Okay. So let's talk about the lungs a little bit. So you have 3 lobes on the right and 2 on the left. Your apical lobes actually come above your first rib, don't they? Right? So if you are positioning for drainage or positioning for ventilation, it's 2 opposite things, okay? So if they're all congested, let's say you have a child with cystic fibrosis or someone with a lot of congestion and you want to drain them, what do you do with gravity to drain a lobe? Do you put the congested area down or above the tree trunk where it's going to come out? Above. So you have to position for drainage, like ketchup bottle, okay? So you have to know where the lobe lives in relation to the tree trunk. So those apical lobes, you actually have them seated upright. Compared to a lower lobe, you're going to have to get the pillows up under them, right? So drainage is congested side up, and you do chest PT to get the drainage out, whether it's percussion, vibration, shaking, or just passive positioning, right? Or they could have one of those electric vests on, and you help them to expel that first. Then you work on getting more air in, okay? And in order to assist them in getting stuff out, you might teach them huffing, right? Especially if coughing hard because they have broken ribs is too painful or they just had heart surgery. Or, a couple deep breaths before they expel, expiratory techniques. Okay? Diaphragmatic breathing. Tell them to make sure their belly fills up and they're not just breathing up here. And then segmental breathing. Are you able to teach segmental breathing? Segmental it's a freaky thing that you can actually tell your lungs where to fill air in. So let's say I had pneumonia on the right side and or I had a fractured rib, and just because of pain, I'm just hesitant to breathe on that side. And so you listen to my air in my lungs and I'm not filling that lung much. You can come over to me and push and compress that lung closed and say, now breathe into my hand. And by compressing it, I can go and breathe into your hand. That's segmental breathing. So in order to get a person to preferentially ventilate a lung, you actually put it down with gravity. So let's say I need to breathe more on my right side. I would be positioned on my right side. It's like making a balloon close so that you can blow it up. If it's already blown up, you can't put more air in it. So for preferential ventilation, you put that lobe down and you say, breathe into that bed. Or you just push your hand on it. But to clear it, you got to put that up so it drains. So just in case they have a postural drainage question like that. Respirations. What are some abnormal breath sounds? Cackles, crackles, crackles, wheezing, wheezing, crackles, rails, bronchi. What is it? Stridor? Is that Stridor, right? What is that? I've seen it. So make sure you know your breath sounds. You may want to look at where the landmarks are to listen to breath sounds. It's not something that we taught a lot in the program in Ohio and did stethoscope breath sounds. We just didn't. I'm not good at it, so I didn't teach it well. I still panic when I see my old program director, who was an advisor to our program. God love her. She still would come around and come to our advisory meetings, and she would talk to my students about certain things. And she still makes me nervous because she was the one that tested us in cardiopulmonary. And I couldn't tell those breath sounds to save my life. She'd play this tape, cassette tapes or whatever. I'm like, I don't know if that is bronchi or rails or wheezing or normal or what. But make sure you know your breath sounds, okay? Make sure you know where those lobes are. All right. Let me see what some key things I have here. Okay. Orthostatic hypotension. At what point is it hypotension? What do you think would be a concern that their blood pressure, adult running low? Probably below 100. You know, if you're running 90 over 60 a lot, now I run that way, but it's only a problem if it's a problem. How would you know you have orthostatic hypotension? Dizziness. What is the cause of orthostatic hypotension? Yeah, so if someone's been bedbound and they've been laying, when you get up normally, what keeps the blood from pooling in your legs and makes you dizzy because there's not enough blood up here? What fights gravity for you with blood? Because the heart pumps it out. What pumps it back up? Muscles. Specifically, what is the sump pump of the body to get it out of the basement? Gastroc, your calf pump. So if they've not been doing calf pumps or walking, they have sloppy veins, and maybe the valves are also weak. So they need that. So what do we do for a patient who can't fix that problem? Compression stockings, right? Make sense? Yep, TEDS. Okay. So make sure you understand that relationship. Hypotension. Okay. Yeah.
And in spinal cord injuries, abdominal binders.
Yes. All right, now, when you exercise, let's say someone comes to you, they have hypertension, low cardiac endurance, and they're actually coming to you for cardiac training. During the exercise session, you said that blood pressure increases, right? How much can it increase safely?
It can only increase like 10 or 20.
Up to 20.
Yeah.
And what should diastolic do? It should stay the same. It can change a little bit, but what should it not do? Drop. Okay. Now, during the exercise session, my heart rate went up. But after 4 weeks of exercising with you, what will my heart rate look like at rest, or my blood pressure look like at rest? It'll be higher or lower than when we started this protocol 4 to 6 weeks ago? Lower. So that's called the effects of training, which is different than a session. During a session, it increases, but the effects of training is it'll decrease. Okay? You just have to make sure that during the session, it's not so high that I'm going to throw a stroke. Like if it's 200, we don't exercise, right? Even though we're trying to get it down. Okay? And then I want to remind you to look over your ABI index. That's your arterial versus your brachial blood pressure comparisons. They're not 1.0 comparison. So whether it's like above 1 or below 1, it gives you a little guide. That's in your big red. Big red gives ABI index. I'd look that up. Just be familiar. There's a lot of similarities whether it's above or below 1. Just a lot of similarities. So just memorize what's different. Yeah, so look that over. Know that your chest PT techniques, what those will be used for, whether it's for getting the congestion out or whether getting air in. Okay, like rib springing is to help increase air. Okay. The other thing would be knowing remember which part of the breathing cycle is active. Which one requires actual muscle activity? Breathing in or breathing out? Breathing in, because the ribs have to lift. We have to create negative pressure. The diaphragm has to drop. And that pressure alone will cause recoil emptying. Now, if you're going to cough or you're going to have forced exhalation, yes, now you use your transverse abdominals and all that for forced. But all things being equal, inspiration is active. So when you give that patient that little plastic thing with a ball, what are they supposed to do? Blow into it or suck in? Suck in, inspire. It's an inspiratory spirometer, right? To breathe in. Okay. Let's see. All right, let's relate this then to temperature, which is another of your vitals. You don't take it a lot, but let's talk about systemic temperature or just limb temperature, okay? So what are the 3 ways you can take a person's body temperature? Oral, rectal, axillary. Which one's the standard measurement and the other ones are a +1, -1, and it's like, ah.
No.
Okay, so this is the baseline, right? We'll say this is ground 0. Is axillary, oh, wait a minute, no, that's not the 0. Axillary is 1 degree cooler, isn't it? And then oral is, rectal's warmer. Rectal's warmer. Oh gosh, look up. Yeah, so that's like -1. This is like +1. I think this might be home base. I think oral might be home base. And then you need to know what constitutes a fever. What's febrile? What temperature is febrile? Above what? 99 point. Normal is 98.6, right? 98.6 is normal. What constitutes a fever?
102.
No, that's a little high.
That's not taking my test.
Isn't it like 99 or like right at 100?
Yeah, I think it's like 99.7 or yeah. God, they don't make you convert Fahrenheit to Celsius, do they?
I've never seen any kind of question regarding.
Also look up when is hypothermia, what temperature? I think it's 97.7 for hypothermia. Can someone look up hypothermia?
They don't do Celsius, and I've never seen a question
With temperature, okay.
other than talking about like orthostatic.
Okay. All right. So you,
Hypothermia is below 95 degrees.
oh, that's really cold. Okay. And do you have febrile? Oh, okay. So don't freak out. And fever is actually the body's good reaction to fight an infection. You don't always want to cut a fever if you can stick it out. It shortens the length of the sickness if you can just fight out the fever and let the person have the fever. That's a little high. Okay, so that's that. Hypothermia less than 95. Okay. Okay, let's switch to peripheral. What happens when you touch my knee and my knee is warm? Let's talk about what that can mean, okay? So there's 2 things. It could be inflammation normal or infection. How many of you struggle knowing the difference? Inflammation versus infection, there's overlap. We know that inflammation is the normal healing process with any injury, surgery, or condition, right? If you have surgery, your body relies on inflammation to heal because the first phase of inflammation is what? What's the first phase? Clotting, right? It's that initial reactive phase, blood clotting, and then you got all the little cells starting to go, hey, mayday, mayday, mayday. And then the next phase is proliferative, which is the rebuilding. And then you have remodeling, right? All right. So what are the symptoms during normal inflammation? It includes warmth, right? Because you have extra blood flow. So the warmth isn't necessarily a sign of infection by itself. What would be a sign of infection? Discharge. What color? Because clear or bloody discharge is normal after surgery, right? That'd be opaque, pussy, green, yellow, smelly. So there's discharge for both. Normal surgical healing, you're going to see some oozing. It should be clear or it should just be clear blood. It's when it becomes colorful and smelly that it's an infection. So there's overlap. Warmth and discharge don't mean infection. You have to have the smelly, and it also has to, extend that, like it's beyond the normal inflammation cycle. So let's say it's 3 weeks later and like, oh, now this thing is broken back open and it's draining. That's not normal inflammatory healing. That's infection. Yeah. Okay. Pain. And you'll have normal pain with inflammation, but you have to figure out, is this pain making sense? Should it be there? Good. All right, real quickly, let's separate heat exhaustion from heat stroke. Which one do you think is worse? Stroke sounds worser. Okay, here's the easy way. Heat exhaustion is everything you would expect. You're hot, you're sweaty, your muscles are wore out. By the time you get to heat stroke, now you're cold and clammy, you're not sweating like you should. That's dangerous. So know the difference. Stroke, the worst one, we're going to put hot here, we're going to put cold here. When things aren't looking right. Chills. When you should be hot and you're cold, you need to get them to the hospital, okay?
What is it? Does it happen in like certain populations? Because I've honestly, after I play, yeah, okay, because I'll like play a sport and then after I get like cold. Like, really
You're probably dehydrated too.
when I drink too much water, it's electrolytes.
Maybe you're flushed out. Maybe you need salt water. You can't drink too much salt water. Okay, excellent. So that's that, okay? All right, let me just throw in a curveball. You're having trouble with your kidney function. You've been taking Aleve and Motrin for weeks because of whatever, which process through your kidneys. Your NSAIDs process through your kidneys. If you're on those for a long time, you can get into early stage kidney failure. Tylenol, which is not an NSAID, processes through the liver. If you have liver problems, they're not going to want to prescribe you Tylenol. If you have kidney problems, you're going to not want to take too much of the NSAIDs. So you need to know what is in your Percocet or whatever that they prescribed for the person during the orthopedic surgery. If they have liver problems and they're taking Percocet, which is basically Tylenol with a narcotic, you could have some liver problems, okay? But let's say they've been taking the Aleve for this shoulder pain, and now all of a sudden, out of nowhere, the blood pressure skyrockets. They're like, oh, they're looking for all these, they're putting them on an EKG and there's nothing in the heart, but their blood pressure is high. What is the connection here? Why would blood pressure be high if for some reason we've irritated the kidneys? What's going on? It's not filtering and also not what? You're not eliminating urine. So you have too much fluid in your body. You literally have too much, too much. So an acute kidney condition can literally trigger and mimic a cardiac emergency. So if it doesn't make sense and you had never had a cardiac problem and all of a sudden, and then you actually find out you have a kidney infection. Like, oh, for the love of Pete, you have a kidney infection. Okay, so that can actually trigger a weird cardiac thing because the kidneys and the heart are so related. So if a person needs to go on dialysis and they choose not to because they don't want to live on a machine and they're like, I'm going to let it pass, they're going to eventually go into heart failure because they are going to overload the heart, and then you'll see their legs swell and you'll see their arms swell. When the arms are swelling from that, it's not long. Okay?
Yellow eyes.
Yeah, probably. Now, real quickly, the connection between CHF and the swollen legs. Don't confuse that with peripheral vascular disease. If it's just peripheral vascular disease, they need to walk hard and rest hard. Walk them, walk them, walk them, get the pump going. And when they're sitting, put your legs up, Grandma, right? If you have arterial problems and you have that droughted yard and there's no pulse, you can only walk as much as you can walk till intermittent claudication pain sets in. And then when you sit, what do you think you're going to do? You're going to put your legs up? No, because you don't have any blood now. It's going to hurt. You leave your legs down. Now, the cardiac patient with swollen legs, the reason their legs are swollen if they have CHF is because the heart can't pump. And to save your life, to save this cardiac output balance, to not die, it's taking some of the fluid out of the bloodstream and putting it into the legs. So it's not great, but it's where they're at. So if you were to put pumps on their legs and put all that water back into their blood system, they're going to get short of breath quickly and you could kill them.
There's no difference between left side and right side nerve failure. We need to know that.
So if you're thinking of the left ventricle, you're right. So the left ventricle, when it gets weak and tired or damaged, the blood backs up to the heart. If the right ventricle is not well, where will that back up? From the body. So you'll see jugular distension. Does that make sense? So the key thing, if you see jugular distension, that means the right ventricle is not pumping well to get it to the other side. If you see swelling in the legs, it's the left ventricle. And that's the simplest, right, classification of the two. Good. Okay?
We're saying that was left versus right heart failure?
Yes.
Mm-hmm.
They still call them the right side cor pulmonale?
You do see that, yes.
Okay.
Yeah.
Okay. This is a huge look, and we haven't talked about pain yet, and this will be fine because this will go right into our safety grid, which is just on the back of that paper. Okay, we're still moving on that. Does this help to see where the data that you collect and the things that you see inform something else, and it might tie into your test question as far as what's really going on and what's your response? Knowing what's normal and not normal. Okay? And the relationship between those systems. All right, you want to take a quick 5 minutes? Okay.